Hello, everyone. Thank you for joining us for our live webinar session today, titled Bronchoscopic Lung Volume Reduction with the Spiration Valve System. I am incredibly excited to introduce our presenter, Dr. Gerard Criner. He is the Chair and Professor of Thoracic Medicine and Surgery at the Lewis Katz School of Medicine at Temple University Hospital in Philadelphia, Pennsylvania. Dr. Criner was the lead investigator for the EMPROVE Clinical Trial and continues to be an industry expert on endobronchial valve treatment. Thank you for being with us today, Dr. Criner. Before I hand it off, I would like to remind everyone to refer to your registration email for instructions on using the Q&A feature to ask questions during the session. You will be muted for the duration of the webinar, but please feel free to submit questions at any time. They'll be addressed at the end, and any unanswered questions will be collected and addressed via email. Now, without further ado, I'd like to turn it over to Dr. Criner.
Thank you, Julia, and welcome to everyone. So as Julia mentioned, we're going to talk about bronchoscopic lung volume reduction with the Spiration Valve System. These are my disclosures. The most important ones for this talk is basically I was funded by Spiration and Olympus for conduct of the EMPROVE trial, and I do consulting work for Olympus. So why are we here? We're here because of the clinical consequences of hyperinflation in patients with COPD, especially those with emphysema, are important, clinically meaningful, and can affect patients' outcome in the most dire ways. The presence of hyperinflation is most consistent or correlative with patients' increased breathlessness, even more than changes or correlations you'd see with FEV1. The reason for that is hyperinflation impairs respiratory muscle and chest wall mechanics, it impairs cardiac function, and thereby contributes significantly to patients' complaints of dyspnea and decreased exercise performance, worsened quality of life. It contributes to respiratory failure in those who require mechanical ventilation. And if you look at the IC-TLC ratio, an index of hyperinflation, those patients who are more hyperinflated are 3 times more likely to be admitted to the hospital or to die from the disease. So let's talk about a patient case of a patient with COPD with disabling dyspnea. This was a 58-year-old male who complained of increasing dyspnea on exertion. He couldn't walk more than 30 yards on the level or 6 stairs without stopping because of shortness of breath. He had no significant cough, no mucus production, and had no exacerbations that required treatment over the prior year. His resting room saturation was 94%, and with ambulation during a 6-minute walk test, his oxygen saturation decreased to 88%. The patient was on maximal medical therapy with triple inhaled medicines as shown there and using a short-acting beta agonist for rescue. He has completed rehabilitation without any significant improvement in his complaint. These are his data shown in the charts shown. To the left is his medical history. He was a male, he was 58. He was slightly overweight with a BMI of 31. He had smoked for 35 pack years. He stopped smoking about 5 years prior to when I saw him in 2016. He had 2 moderate exacerbations in the last year, none required hospitalization. He was gold grade 4, severity of airflow obstruction, gold grade 4, dyspnea by MMRC. He had done rehabilitation previously, and he had received vaccinations for influenza and pneumococcal vaccine. As you can see from his pulmonary function test to the right, the patient was severely obstructed with an FEV1 that was 17% of predicted and did not respond to bronchodilator therapy, so irreversible severe airflow obstruction, and a patient was hyperinflated with a PLC of 7.99 liters. These are the patient's chest imaging, his chest X-ray to the left, and his axial image of his upper lobes with his chest CT to the right. As you can see from the chest X-ray image, the patient was hyperinflated, small heart, low flat diaphragm, and the patient had some greater lucencies in the upper lobe areas. When you look at the axial CT, you can see the patient had a prevalence of upper lobe predominant emphysema. So let's read the patient case. We'll come back to that later and look at the IMPROVE study objectives and methods. So what was the purpose of IMPROVE? Well, IMPROVE was the PMA submission for FDA for approval of the Spiration Valve System. The purpose of IMPROVE was to evaluate the safety and effectiveness of the Spiration Valve System in 172 patients with severe emphysema. The IMPROVE study was a randomized controlled study. It was designed to demonstrate the ability of the SVS to be safely deployed in selected airways of human subjects with the purpose of improving lung function. The key inclusion criteria were these: FEV1 was less than 45% of predicted, PLC was greater than 100% of predicted, and patients had a residual volume greater than or equal to 150%. The randomization was 2-to-1 to treatment versus standard of care. This was optimal medical management as standard of care. In the SVS treated group, they received optimal medical treatment, plus they had intervention with the SVS system for total lobar occlusion. Pulmonary rehabilitation was required prior to enrollment, but was not mandated through the follow-up period. As the primary and secondary effectiveness endpoints were measured at 6 months, but longer-term durability of effectiveness was measured at 12 months following randomization. One of the important features of the IMPROVE study was that the high-resolution CT scan was pivotal for patients' eligibility and assessment for fissure integrity. The most diseased lobe was selected based on the HRCT. The treated lobe had to have more than 40% emphysema and a greater than 10% difference between the ipsilateral treated lobe and the non-treated lobe, with the middle lobe not being considered in this analysis. The selected lobe had to have an intact fissure greater than or equal to 90% compared to the ipsilateral lobe that was not treated. And the HRCT analysis for IMPROVE was performed by MediQA Core Lab using VITA diagnostic software. The safety and effectiveness endpoints are shown on this slide. The primary safety endpoint was the incidence of thoracic adverse events through the first 6 months. The primary effectiveness endpoint was the difference between treatment and control groups and the mean change in FEV1 from baseline to 6 months. The secondary effectiveness endpoints were the difference between the treatment and control groups and the mean changes from baseline to 6 months for the following parameters: targeted lobe volume reduction measured by the quantitative CT, hyperinflation defined as the ratio of residual volume to total lung capacity, health status specifically measured as COPD by a St. George Respiratory questionnaire, dyspnea again measured as we previously mentioned by the Medical Research Council modified questionnaire, exercise capacity by 6-minute walk distance, and a responder analysis for FEV1 defined as those achieving greater than or equal to 15% improvement in FEV1 at 6 months and then again at 12 months. This is the primary endpoint of IMPROVE for determination of improved lung function. This is the change in FEV1 to the left of this graph shown at 6 months and then at 12 months. As one can see, at 6 months, the change in FEV1 from baseline in the IMPROVE treated group with SVS was 100 mLs. And then at 6 months, the intergroup difference remained at 100 mLs as shown to the right. So it showed a significant improvement in 6 months with durability of the treatment response in FEV1 at 12 months. This looks at the secondary endpoint, reduced hyperinflation, a key outcome of the IMPROVE study. And as you can see, the reduction in the RV to TLC ratio was about 4% at 6 months in IMPROVE. And if one looks at the right side of the graph, you can look at the secondary endpoint, the targeted lung volume. As one can see in this cartoon, looking at the left upper lobe, What happened overall was about a 1 liter reduction post-treatment in patients with the IMPROVE study is a mean difference, 0.974 liters in the targeted load. One can see in the bottom of this the degree of atelectasis that about 40% of the patients had complete lobar collapse in the IMPROVE study. About 50% of patients had a greater than or equal to 50% reduction in targeted load with treatment, and 75% of patients met the meaningful clinical important difference in a responder analysis for targeted load volume reduction of a greater than or equal to 350 mL. This slide looks at other parameters such as improvement in quality of life and reduction in dyspnea. To the left, you can see that SGRQ was reduced, and reduced SGRQ is an improvement with using this score by about 13 points greater with the patients that received SBS compared to the control population receiving standard of care or optimal medical improvement. And you know that the meaningful clinical difference for improvement in quality of life using the SGRQ is 4 points, and this was triple in the patients who received SBS volume reduction. You can see at 12 months, this is a durable treatment response. This was 2 times greater than the MCID at 9.5 points difference at a year. If you look at breathlessness reduction, it was 0.6 points lower. Again, a lower score is an improvement with using the MMRC score at 6 months. And this was the same and durable at 0.8 point reduction with the patients that received SBS treatment at 12 months compared to optimal medical treatment. And this is, as I mentioned before, the responder rate analysis. I'm showing this at 12 months on this slide. And you can see that those who received a greater than or equal to 15% improvement in FEV1 at 12 months was 37.2% of the population that had SBS treatment in the left, compared to optimal medical treatment with only 5% to the right of the slide, showing that greater than 30% of the patients received greater than 15% improvement, more so than the ones with optimal medical treatment at 1 year post-randomization treatment. How about pulmonary adverse events? The only statistically significant adverse event within the first 6 months, and especially within the first 30 days of treatment, was a serious pneumothorax that was seen in 14.2% of the patients that received SBS treatment. This definition, that was an a priori definition, included those patients that had a chest tube in place greater than 7 days or had some other surgical procedure to treat the persistent pneumothorax. Acute exacerbations and pneumonia in non-treated group were numerically higher in the patient group that received SBS, but that was not statistically significant. And when one looks at the serious adverse events in the long term, these tended to approach the control group as the patient group was followed for a longer period of time. So the conclusions of IMPROVE and the IMPROVE study has now been published online in the American Journal of Respiratory and Critical Care Medicine, showed that bronchoscopic treatment of severe emphysema with the Spiration Valve System provides statistically significant and clinically meaningful improvements in FEV1, targeted load volume reduction, reduction in dyspnea, and improvement in quality of life parameters with an acceptable and good safety profile. Furthermore, this study demonstrates that using the HRCT is effective in choosing appropriate patients by the degree of emphysema and a targeted load for treatment by looking for fissure integrity. These patients achieve effective bronchoscopic lung volume reduction. So let's go back to our patient. Remember the patient that I described to you who had disabling dyspnea and had irreversible severe airflow obstruction. The patient was entered into the IMPROVE study in 2016, and he has treated left upper lobe with complete volume atelectasis or complete lobar atelectasis, so left upper lobe. If you look at the right, his improvements of lung function, his FEV1 improved by 40% at 6 months post-treatment that was durable at a year. I now have followed this patient for 3 years, and these effects have been sustained. His total lung capacity decreases by about 0.5 liter, and his residual volume decreased by 1.4 liter. This was associated with a stable DLCO or slightly increased over time when related to alveolar volume. These are his axial CT images, the lung windows to the left and the soft tissue windows to the right. And you can see total lobar atelectasis is better demonstrated than seen in the chest X-ray. So our summary overall, endobronchial valve treatment with Spiration Valve System can produce a clinically meaningful and durable reduction in expiratory lung volume. The reduction in lung volume correlates with improvements in lung function, quality of life, and reduction in breathlessness. Patient selection, lobe selection, and complete lobar occlusion are key variables for this treatment. Reassessment of valve placement, whether that requires HRCT for looking for proper placement as well as target lobar reduction. In some cases, repeat bronchoscopy if that improvement is not maintained to make sure that the valve placement is perfect overall over time, are necessary if the clinical goals of lobar atelectasis are not met. The side effects overall for this treatment, which are basically a pneumothorax or an exacerbation of COPD, require the presence of a skilled multidisciplinary team that are knowledgeable in the treatment of a pneumothorax, but also in the treatment of a COPD patient. So thanks very much. Be happy to take any questions.
Thank you, Dr. Criner. That was a great presentation. So before we move on to the questions from the group, I'd like to ask you a couple questions. So you just reviewed the improved clinical benefits with us. So I'm curious as to what kind of impact these benefits translate to the patients' lives that you're treating.
Well, overall, patients with COPD, especially those with emphysema, who have been maximally medically treated, who are still symptomatic from breathlessness, that is to them the most important symptom that they have. And their desire in most studies that query patients with an unmet need is helping my shortness of breath and reducing that so I can have a better quality of life, and mainly in terms of exercise performance. Just performance of the activities of daily living are key to them. So I think it's the reduction in breathlessness that allows patients to do more, be less short of breath, and overall better quality of life.
Great. So going along the same lines, and now that the valve has been in commercial use for some time, how has this changed your practice?
Well, it gives another treatment that you can put into the mix to treat patients with irreversible airflow obstruction. This isn't for all patients. About 25% of the patients that present to physicians who meet that kind of profile will probably be eligible for a valve treatment, mainly because they have a lack of leak between the lobes called collateral ventilation, which is surrogate measured by fissure integrity. Unfortunately, that only is about 30 to 40% of the patients that we see with emphysema right now who have breathlessness. But in that patient group, it can be an important adjunct to their therapy.
Right. So, and as you know, to find an appropriate patient for BLVR, it involves screening many different patients, like you just mentioned. So what was one of the biggest challenges for you in developing your referral network to find the appropriate patients to treat?
Well, I think overall, it's important to make sure patients are medically maximally treated. There is benefits for even decrease in expiratory lung volume with inhaled bronchodilator therapy. That can have a significant role to play, and that can decrease residual volume in some studies by 300 mLs overall. And it's important to note in the patient studies like EMPROVE, those patients had already received that therapy, and the benefit with a structural change was additive to the medical benefit that those patients already attained. But if you're seeing a patient who's naive to that therapy, giving him that therapy is important. Plus, rehabilitation can decrease air trapping by making patients stronger overall and improving their ability to have better respiratory pump function. Supplemental oxygen can be helpful by slowing their respiratory rate and deflating them somewhat. Changing how they breathe sometimes and using pursed lip breathing can have an important adjunctive feature. Once you go through all those, then looking at some other form of more potent treatment for hyperinflation is key to the treatment. That might be an endobronchial valve in patients that have don't have an intact fissure overall or collateral ventilation positive. That might be lung volume reduction surgery. And patients that are too severely impaired, who have poor lung function overall, or maybe a additional comorbid condition, secondary pulmonary hypertension, that patient might be reserved for lung transplantation. So it's key to think of this as one other therapy added to optimized medical therapy and looking into the landscape of other therapies that you might need to treat a patient with severe hyperinflation.
Great. Now let's turn it over to our attendees' questions. All right, let's see. So what was the average duration of hospitalization post-pneumothorax?
Overall, it was about 4.5 days overall, I believe, in the study.
Okay.
But it was longer with the pneumothorax overall. So with patients, the average was that, but if they had a pneumothorax, it might be 14 days.
Okay. All right, let's see. So the next one, what value do you use as a cutoff for determining if a patient has pulmonary hypertension?
That's a very good question. So at our institution, we routinely do an echocardiogram. If it has good windows, we use that result. If that good echocardiogram shows a pulmonary artery systolic pressure less than 45, we'll go ahead. If we can't visualize we can't make the estimates of the pulmonary artery systolic pressure, or they're higher than that, we'll proceed for right heart catheterization. If on right heart catheterization, the PA pressure is less than 45, then we'll proceed with SVS treatment. If it's higher than that, then we will consider other treatment.
All right. Okay. Is there a mortality benefit to this procedure?
That's another good question. Well, we don't know from any of the prospective randomized controlled trials with endobronchial valve therapy, and in this case, the SVS system, because those studies were too short and too small in number overall. There is some post hoc analysis that's been reported by a group in the UK, Nick Hopkinson's group, as well as a group in Heidelberg by Felix Hurst and Danielle Goppelman, that showed in those patients that had complete lobar atelectasis, there was a survival benefit in post hoc analysis overall. Now, we hope that that will be the case, but we'll have to wait till the registry, which is mandated by the FDA, are completed in determining whether there's any treatment survival benefit in patients with lobar atelectasis compared to comparable patients that aren't receiving this form of therapy.